you all so much for joining us today. I want to start out by looking at where we were a year ago. Last year, about this time, we asked the hospitals that were joining this initiative to do the A1 postpartum hemorrhage preparedness survey. Got some slides here showing what the results of that were. And hang on, having a little trouble advancing the slide. There we go. The three questions we were talking about were quantification of blood loss. We had three different things we looked at. One was, how do you measure blood loss for the first one, from birth through the first 1 to 2 hours on a vaginal birth, from birth through the first 1 to 2 hours on a cesarean birth, and then if you have abnormal postpartum bleeding, and this continues for anywhere from 3 to 12 hours, does that change the way that you're measuring? Our choices were a visual estimation only, blood collection measured in a container plus visual estimation of blood loss, or actual weighing of blood-soaked items plus measuring from a container. And what we see is that with the vaginal birth, we had 15 out of 36 hospitals that were doing visual only. That's the majority. That was at 42%, the majority. About 11 were weighing and measuring, and about 10 were measuring and visual, and that's approximately 30% on each of those. After a cesarean, we were doing visual only for 12. We were doing measured and visual, so I'm assuming they were measuring what was in their canister and then visually estimating their laps and linens. And for that, we got 15 out of 36, which is about 42%. About 33% on the visual only, and about 25% were actually weighing and measuring. Now, it changed a lot when we realized that we had a bleed and we were going to be watching them longer because of a situation that was going on. At that point, we went to 81% of you were actually weighing and measuring at that point. But we still had a minority of 19% that were doing visual only. So we're going to kind of move forward with this and see where we've come in the past year. I think we've talked about this before, but why is it so important that we move to quantitatively measuring blood loss? We know that we're very inaccurate with visual assessments. There are a lot of studies out there that illustrate the difficulty and the inaccuracy of estimating blood loss. We are off by as much as 50% with these. So if we are estimating that we've lost 1,000, we very likely have lost 1,500. By having this improved accuracy, we hopefully will decrease our response time. That wait-and-see attitude. I know early in my career, and I'm sure a lot of you more veteran nurses on this call have been through this too, that she'd bleed a little bit and, hey, it'd get better, so I'm hoping everything's okay. It'd look better the next time, then she'd bleed a little bit more. And I'm sure there were many times that I was a bit behind the 8 ball before I realized it. And I think that's kind of a common problem when that happens. One of the other things is that we've also talked about the hematocrit not really reflecting blood loss until 4 hours after the incident. And I was actually reading something this past week that kind of knocks that out of the water. It was a hematology text, and it was the chapter on transfusions. And one of the things that it was saying was that that full volume expansion, where your body physiologically starts pulling water, your albumin starts pulling water to where it belongs, and that's when your crit is going to be at its lowest level because of the hemodilution that's going on with that. That actually doesn't show until 60 to 72 hours. Most of our moms are home at that point. That's why it's so important that we see what amount of blood they're losing, because they may be hanging in there, their vital signs are okay. They're up walking around the room at 24, 36, 48 hours, but then we send them home to take care of a baby, and the stresses of that and trying to breastfeed with less blood volume, and it hits them a day or two after that. And so it's very important that we kind of know what we're sending them home with. One thing it makes me kind of sad is that we tend to judge the quality of care by whether we're looking at a postpartum hemorrhage or not by definition. Really, we need to be looking at what is the quantity of blood loss. Let the quantity itself tell the story. Postpartum hemorrhage happens. Even slightly increased blood loss happens. It's not anyone's fault. It's the nature of the business that we do, that we're in. And I think a lot of practitioners don't want to admit that, oh, there was 700 here instead of 500, or there was 1,200 instead of 1,000, because then it looks like I've had a postpartum hemorrhage, when really we just need to be measuring and paying attention. It's about the communication that goes on with this. I know in 2013, when we were doing all the Oklahoma postpartum hemorrhage courses that we did in Oklahoma City, Tulsa, and Lawton, when we would have the physicians in the little breakout session, one of the things we heard over and over again from them was, yes, I want to know how much. It's so much easier for me to identify what I need to be doing if when the nurse calls, she tells me I've had 800 cc's or I've had 1,200 cc's, versus saying, well, she saturated this number of pads and the blue pad was really full. They don't know what to do with that. So it's so much better with our communication if we can say she's lost 1,200 mils of blood, she's in a stage 2 hemorrhage, and that's about a 20% blood loss, blood volume loss for that patient. And so those are the things that we need to be looking at. Are we effectively communicating so that we can react the way we should? One of the other problems is having all these hard stop definitions. It's a little challenging in the clinical situation to say 500 vaginal birth, 1,000 mils for a C-section birth, because we all know that it's not always that black and white in the clinical setting. If I've lost 700 at delivery, but now my bleeding is controlled, she's hemodynamically stable, and the bleeding is now really tapered off, and I've just got a scant amount of blood during the recovery phase, do I really want to jump in and do anything about that? Or is it just more a matter of increased surveillance? The big important thing, again, is that follow-through with communication. Is the next person that's following you, the next practitioner, the next care provider, do they know how much she lost previously? So if they have any increased bleeding after that, they know to add to that. It's that matter of heightened surveillance versus transfusion. You know, if I'm somewhere between 500 and 1,000, I'm probably on a heightened surveillance. Transfusion, I may not want to start a transfusion until she's over 1,000 for a vaginal delivery, over 1,200 for a C-section. A lot of the literature suggests that when we're at 15% down, that's when we might want to start a transfusion. One of the best resources we have is A1. I don't know if you all are familiar with this page. What did we do here? Thank you. We go to their page on postpartum hemorrhage. They've been doing a project with DC and 2 other states. I think it was Georgia and Virginia. New Jersey. No, somewhere up there. And they have now completed that project. They're collecting the data, and that will be available to us in the future. But if you look at this page, one of the best things they have is this quick little video on quantification of blood loss. I think it's approximately a 3-minute video, and we're going to look at that in a minute. Down below that, you're going to see all these resources that they have. They have got their practice brief on quantification. They've got their whole OB hemorrhage monograph, which is like a small book. Great, great information within that. A lot of didactic content of the background of why we're doing what we're doing. They've got 3 different webinars that are really great. They have a copy of the Joggin issue that was based on OB hemorrhage. They've got an online education module. There's a lot of good resources here that I really think would be important for you to access. Right now, we're going to take just a couple of minutes and look at this video.
The United States is ranked 47th in the world for maternal mortality. Obstetric hemorrhage is the leading cause of maternal mortality in the United States, and 54 to 93% of these deaths are likely to have been prevented. Obstetric hemorrhage-related mortality is only the tip of the iceberg, since research shows that about 125,000 women every year in the United States will suffer from an obstetric hemorrhage, 2.9% of all births. A leading cause of preventable maternal mortality and morbidity is failure to recognize or late recognition of excessive blood loss during childbirth. Women die from postpartum hemorrhage because they do not receive early initiation of effective interventions. The most accurate way to recognize the amount of blood loss is by direct measurement and cumulative quantification. How do you quantify blood loss? Weigh blood-soaked items such as peri-pads and lap sponges. Measure using calibrated devices such as under-buttock drapes and containers. First, let's talk about weighing blood loss. To establish the amount of blood loss, place the blood-soaked items on a scale. Subtract the dry weight from the blood-soaked weight to determine the volume of blood loss. As a general rule, 1 milliliter of blood weighs approximately 1 gram. For example, if the dry weight of an item is 40 grams and this item weighs 140 grams when saturated, then 140-gram wet weight minus 40-gram dry weight equals 100 milliliter blood loss. Make sure you weigh all blood-soaked materials and clots. Now let's talk about measuring blood loss using containers. Measure using graduated or calibrated suction containers and under-buttock drapes with calibrated pouches. Remember to subtract other fluids such as amniotic fluid or urine. For example, the under-buttocks drape equals 750 milliliters minus 250 milliliters irrigation equals 500 milliliters blood. However, it isn't always this straightforward since it's hard to know how much urine or amniotic fluid are in an under-buttocks drape. One strategy that helps more precisely measure actual blood loss is to document the amount of fluid collected in an under-buttocks drape prior to delivery of the placenta, since most of the fluid collected prior to delivery of the placenta isn't blood, and most of the fluid collected after the placenta is blood. Be sure cumulative blood loss is documented by keeping a running total. Women are the cornerstone of a healthy and prosperous world. We must act now to eliminate preventable deaths and injuries. Quantification of blood loss at every birth will help save women's lives. For more information on A1's Postpartum Hemorrhage Project, please visit www.ppHproject.org. To download A1's summary of the research on quantification of blood loss and to access the practice brief with tips and references, go to www.pphproject.org/resources.asp.
We're going to talk a little bit more about methods of doing that in a minute, but right now I want to look at where we are today with our AIM Data Center results from quarter 4 and quarter 1. Hang on just a second. There we go. Okay, so looking at our data that we have collected for the 4th quarter of 2015, and this is everything that that one's been completed, and we were looking at 45 hospitals, 7 of which have been able to maintain a 90 to 100% of their mothers having quantitative blood loss measurement. Got a couple of hospitals that were between 80 and 90, and then as you can see, it kind of drops down from there. If we look, and that ended up being about 16% of them of the hospitals in Oklahoma are doing quantitative blood loss on all their moms. And now if we look at the first quarter of 2016, and as Barbara mentioned earlier, we only have about half the hospitals that have entered data at this point. But out of the 30, we have 1, 2, 3, 4, 5. So we've got 17% at this point that are doing 90 to 100%. And again, this kind of drops off. Overall, when we look at this, about 30% of women in Oklahoma are having a quantitative blood loss done at each delivery. So we're going to open this up for discussion in just a moment. I would like to, let's close that out. I would like to do the polling question. And what we want to know is quantitative blood loss part of your daily practice on all births? And you'll be able to see the polling numbers roll by here as people answer. So if you can just check A, B, or C. We've got about 15 seconds, and over half of you aren't answering, so see if you can pick one of the answers in the above. Okay, so everybody can see it now. Okay, so as you can see, 2 of the hospitals are doing quantitative blood loss. 7 are not. No one said they didn't know, but we have 9 that just didn't answer the question. So at this point, I'm gonna ask some questions, and this is just general discussion at this time. This is what we wanted to have everybody here for, not anything other than trying to learn from each other. So if you're not doing quantitative blood loss on everybody, are there some deliveries that you're targeting that you are doing it on? Are you doing it on C-sections? Are you doing it on just ones that you identify as being bleeding heavier than normal? What is your practice at this time?
So this is Teresa Gibson from OU. We typically do not do quantitative unless the patient has excessive bleeding, in which case we start measuring.
Okay, at that time.
Uh-huh.
Okay. Anybody else? I have a feeling that might be a fairly common practice from what yesterday's webinar showed.
This is Angela at St. Anthony's. Our hospital system is actually implementing quantitative every delivery. And so we're piloting it at a hospital. I think they're similar in size to OU that's in St. Louis, and then we'll be going live with it in all of our hospitals hopefully late this summer, early fall.
So you all are in the process right now?
We are. I mean, we're in a pilot, not at our hospital, but by the end of the year, we're looking to be doing it in all deliveries unless that timeline changes, yes.
Okay, good. Anybody else got something to add that?
Barbara, this is Jill at Canadian Valley.
Mm-hmm.
And we, as a system, currently we do ours similarly to the ones who said that just if it looks as though there's, significant bleeding, then we're going to begin to quantify, or suspicious of bleeding. But we are also, our OB Consortium has created an ad hoc side group, and we've just done that. That's going to begin to work on implementation throughout the system of quantitative blood loss. So we're just working on that process.
Okay. So it sounds like a couple of the systems are kind of trying to get it together so it goes live for everybody close to the same time.
Yes.
Any other, like, independent hospitals that are doing anything differently? I think my question my comment to, we're measuring when we recognize that they're bleeding, knowing that we don't recognize it until it's usually a little further along than we think it is. Are you including that, your estimation in that? Are you going back and getting all of your linens and such from the delivery, hanging on to those, and then weighing those at that time? Or are you saying, well, we had estimated 700, and now she's bleeding heavier, we're going to start measuring, and I'm just going to add that 700 estimation to it? How is that happening?
So this is Teresa from OU, and it depends on how far into the delivery we've recognized that we've got excessive bleeding.
Mm-hmm.
If it's possible, if we're still in the delivery room or still in the OR, then yes, we are going back and measuring what's there. If it happens when the delivery's already cleaned up and all that is already taken away, then we use the estimated and add it to the quantitative.
So really, if you recognize it at the time of delivery, you can't ask for any more than that. I mean, that's when anybody, even at their best, can say, hey, I'm sitting here in stirrups, or I'm on the table and, massaging her uterus after the section, and whoa, I got more blood than I intended. I mean, you can't ask any more than to measure at that time. I think the only problem occurs is when they're, have gone out to postpartum and we haven't measured anything.
Right.
Or two. Yeah, we've thrown everything away. So really, it sounds to me like if you're doing it in the delivery room at the time that you recognize it, you can't ask for more than that.
Right.
So I'm kind of curious as to what kind of barriers the various hospitals are finding as to not being able to establish this practice. I know some of the things that we have heard are trouble getting the UB drapes, the underbuttocks drapes that are graduated, getting that through the system, getting them into their packs. That should be something that with a little bit of time you can get fixed. One of the other things that we hear is getting it through committee, and it sounds like some of you are in that process now with the systems thing, and I understand that just takes a little time. One of the things that we've heard that we probably need to address is physicians not wanting to wait to see what the estimated loss is. Are any of you running into that?
Attention, the Pesco 2 down for me.
So is that something that any of you are running into, the physician saying, I don't want to weigh that, I'm out the door?
Maybe an acceptance of overall this has been slow sometimes with certain people.
What do you mean acceptance? That they don't want to wait, or that they don't care to know what the blood loss is, or?
I think maybe a couple different reasons, but
okay.
I'm sure we're not unique in that.
Oh, I don't think anybody is experiencing anything that is unique, and if all of you were actually honest and just vomited up everything you're thinking right now, we'd have a whole lot of common ground. One of the other things I think that we get into with physicians and nurses, this isn't just about them, but we've got this usual practice of some institutions, every vaginal delivery has 400 cc's at delivery, unless it truly is a hemorrhage. Every section has 800, or maybe certain physicians that, Dr. A is always going to be 300, Dr. B is always going to be 250, Dr. C is always going to be 400, and so without even glancing back, they just give you a number, and I think that's a habit that we need to work on breaking.
Barb, this is Terry from Integris Baptist. I was wondering if maybe we could hear from the two that said that they're doing it, maybe how they've managed to get it done.
Yeah, I was about to ask, I know we've got at least 3 hospitals on the line right now that have been good with, just 2 now, that have done this pretty consistently. One is Jane Phillips, and the other one is St. John. And I would love to have any of you ladies speak up and tell us how you got through this.
One more thing, too, Barb, before we maybe get some answers, is some of the things we hear from our physicians is that they don't need that they look at the patient and they use their clinical judgment, that's just information that they don't feel is necessary. They're there at the delivery, they make that assessment, they expect the nurses to be on top of that. They think it takes too much time. There's all kinds of reasons why, but a lot of them say it's not going to do anything to change how they practice.
Okay.
And what I think a response to that would be, the evidence showed that if we are estimating, we tend to underestimate. And maybe if you knew exactly how much blood they were losing, it would change your practice, because we're probably going to be, at 500 if we're measuring than we would have been if we're estimating. So in reality, you are probably going to intervene more quickly if you have a quantitative blood loss measurement that is cumulative.
So are they okay with you measuring once they leave the delivery room so that you can let them know later if there is an increase in bleeding?
Yeah, I don't think they care one way or the other as long as what we're doing is not interfering or slowing them down, or again, it's just kind of a strange, I don't even know how to explain it. It's like they feel like the nurses are doing a lot already, and it's, busy during delivery. The nurses are occupied with mom. We have to rely on our scrub techs to help us, especially with visualization of the underdrape, when there is that fluid or urine or whatever prior to delivery and the actual blood loss. So I don't know. I don't think they are really seeing the.
They don't see a benefit.
Right. That they're there. They see what's going on. They follow with lab, and we know how that changes drastically even in an hour. But it's just kind of a different. I guess they're not used to that being a part of their practice, so they, it's something new to them. So.
There's a lot of new or new as old again over the years. One of the things I can kind of think of comparing this to is, 80 to 100 years ago, nurses didn't do blood pressures either. And I would think that I waited until a patient was symptomatic before I knew her blood pressure was going down, and I wait for her to get symptomatic, and then I decide to take a blood pressure, go, you know what, yeah, she really is hypotensive. So that's kind of the analogy I use in my head, although that probably wouldn't hold water with them under the circumstances. But back to what Terry said about let's hear from Jane Phillips or St. John about how they're working with this.
This is Carol from Jane Phillips, and last fall we did our drills, and we required that all of our physicians attend the drill, at least one. And we kind of educated them at that point that these are the questions we're going to be asking you, and this is the expectation. And they do pretty good.
So did you run into that, them thinking that, or them stating that your measuring of blood loss was inconsequential to their visual assessment of the patient at that time before they leave the room?
Nobody said anything. I don't do like a lot of deliveries, but nobody has complained of that.
Okay.
Can I ask a question? When you said you required that all your physicians come, exactly who required them to come? Because that could be a challenge.
we talked to the medical director, and him and the nurse manager in the unit met with them at their monthly meeting and stated we were going to do these drills, and this was the requirement.
So you had support from your physician and your nursing leadership.
Yes.
And that can be difficult. We recognize in some hospitals that support is not there. We are available to come meet with you all. We are going to be doing some simulation training and other things, and having our physicians here come talk at an OB staff meeting, a medical staff meeting. If you think that would help, we're available to do that. But that's not uncommon to lack that support from the top. Holding, you have to hold them accountable. If they're not going to come, then what happens? That can be a challenge. So, and it may be something that changes slowly over time, that it doesn't happen overnight. But just know that if you do need help with that, we're willing to work with you, and if we can help you, to see how that's going to get done. What about you all at
St. John?
At St. John, or that was St. No, that was Jane Phillips. At St. John?
This is Kristen Waltz. I'm from the medical center at St. John. I think we probably could have answered that question a little bit differently, in the fact that we don't measure every pattern or every patient after every delivery. We are kind of falling into that group that look at the quantity of blood that we're losing, and then we kind of have a discussion. Each of our deliveries, vaginal deliveries and C-sections, the discussion is had between the physician and the nurse. What is your EBL? That way that discussion is started with the physician right then, that, all right, we're on the same page as far as what her EBL is at the delivery, so that we can base the rest of our quantitative measures off of that. And so if the nurse at that point feels like, that fundal check was a little bit heavier than I expected it to be, I'm going to go ahead and weigh that pad. And then if we start moving in that direction, then we have already had that discussion with the doctor. Hey, we've already discussed this. She was a little bit heavy at delivery, and now I've had this much out. And we're going to go ahead and start the protocol to start treating her. So those are kinds of the discussions that we have. Again, we have really great physician practices here that we do, like Jane Phillips, kind of get our physicians on board. It gives us a lot of autonomy, too. It puts the trust of the nursing staff with the physicians to say, hey, we've trained together. And I think after the fact of, everybody's met, everybody's gotten on board with different new changes in our policies, the physicians do kind of appreciate. I'm glad that I took 30 minutes of my day to come and do some training with the nurses, because now I feel like we're going to be better with our shoulder dystocias and with our postpartum hemorrhages and things like that. It is challenging to get them to participate, but once you do, I think it does change your relationship. So.
Anybody else have any questions of these ladies, of these two hospitals? Or any others. Something that I'm thinking is, I know that you did, I'm thinking of what Carol said about doing the drills and getting the physicians on board and everything like that. How did you actually start with doing QBL? And I would love to see us get to the point that is our, that's our vocabulary versus EBL, but again, things take time. How did you all start that? Did you start with getting the nurses on board with how do we measure? Did you start with one particular type of delivery?
Stephanie started
all at once
at Jane Phillips by, she set up a room, kind of like what you set up down in Oklahoma City, and let everybody guess. And then we also had an in-service and staff meeting, and that kind of got the nurses thinking about it. And then we did the drills. And then I think the final thing that really gave a lot of nurses buy-in is we had a patient with some bleeding, and I think we guessed about 1,200, and she actually lost about 2,800.
Whoa, yeah.
So it was like, wow, this just kind of quantified it all, Yeah,
that would definitely open your eyes. It's a shame we have to have experiences like that to get buy-in, but sometimes that's what it does.
I just did, this is Angela, I just did some drills with all of our staff, and I did use a scenario, and it was fake, but it was very believable. And so when I talked about quantitative blood loss at every delivery, and people's faces, and so then I had used a scenario prior to talking about that is coming to our facility. And at the end of the discussion, a majority of the staff was really like, you know what, it's going to be a little harder, but it makes sense. So just even having something to kind of get them to buy in changed the way they were thinking about it. We'll see how they feel when we roll it out, but even in just our meeting about it.
Well, I think something that the two of you have brought up is attitude does trickle down so much, and the fact that both of you have gone at this with, this is something we need to be doing for the patient, and from safety practices makes a big difference. Again, it's a big paradigm shift for all of us. Remember when we went to Mother Baby and the pediatricians didn't want to do their assessments in the nursery, or the obstetrician wanted you to take that baby over and weigh it immediately, or the nurses felt like we had to get all of our work done before the delivery and recovery were over, so we were doing the eyes and thighs bath and, now we realize the best thing is to keep that couplet together. And, yeah, we still have to do temperatures and a couple of things, but so much of that is for our convenience and not for the best care of the patient. And it's, some of us went through that back in the 80s and 90s. Some of us are still going through that. But, again, it's that whole paradigm shift in not what's easiest for me or best for me, but what's best for the patient.
It's a webinar.
So,
and I think another, just to emphasize what Barbara said, and she's going to talk a little bit more here, that the quantitative blood loss, it is a few more steps, but it really isn't a whole lot more than what you're currently doing. But one thing, it can be very overwhelming to make a change, and it kind of paralyzes us where we just don't know where to start. So, think about your equipment, even those of you all who are waiting on system policies or something like that. Do you have the equipment? Can you go ahead and start getting the graduated underbuttock straights? Do you have your scales? Do you have all of those things ready? Can you just start with vaginal deliveries and then move to, or can we start with one shift and then move to another? So taking baby steps where you don't have to do the whole change everybody all of a sudden one day, that can be rather difficult. And so think about how can we start this and take a few steps forward, because this is one of our priorities, is for you all to be practicing quantitative blood loss. And I think in a year or two, we'll look back on this, as Barbara just said, and said, remember those days where we thought that was going to be such a challenge, and now it's just part of our daily practice. So think about where can we start in our hospital, what will work for us, and go ahead and make some steps to move forward. And I'm going to turn it over to Barbara here, and we'll open it up here for some questions in a second. But she's just going to talk a little bit just about the actual process.
I know that it's, again, we keep saying, well, it's just one more little thing. It's just one more little thing. And I know that in itself becomes overwhelming. But the inertia of not doing anything is terribly paralyzing. So if we can look at doing QBL in just 2 steps with a vaginal birth, just look what's in the drape before and after the placenta, like the little film said, and then what is the cumulative blood loss at the end of a 2-hour recovery. Now, truly, if I have somebody that I feel like is bleeding heavy, I may want to weigh that more frequently. But if we're talking about the average delivery, the ones that you all are recognizing right now probably are not a hemorrhage, but we just need to make sure. Have a red bag on your scales. Know what that weight is. throw your pads in, count how many you threw in, throw in your blue chuck, how many of those you had, and just weigh it all at the end of the 2 hours. Now, certainly some cases you're going to have to do more frequently. Some of them you're going to have to extend that to 3 or 4 hours. But it sounds like quite a few of you, when you recognize somebody's bleeding heavily, are doing that anyway. So if you can just have your red bag, you're throwing everything in it, at the end of your 2 hours, weigh it on those that are what you would consider normal. And that way you can actually then, another way of saying this is, I'm not proving that they had a hemorrhage, I'm proving that they didn't. So if that helps your physicians any, is that, you know, kind of CYA by saying, you know what, they didn't bleed very much. And so if they start bleeding a little more in postpartum, then we can pick up on it at that point. And same thing with the cesarean birth. I know the film talks a little bit about subtracting irrigation and so forth, but I think there's a simpler way to do this, and that's that we're going to suction the amniotic fluid after the delivery of the infant, have the scrub tech signal for the circulator to switch canisters, just unplug one from one, plug into the other at the end of the uterus repair, but before they start the irrigation, because most of the bleeding happens during that uterus repair when they're looking around before they start irrigation. Measure it at that point. Collect your sponges during the whole closure process, and just like now we give them a sponge count at the skin closure, give them a sponge weight at the end of the skin closure and add those two things together. So it really kind of simplifies things. One of the problems with trying to subtract the irrigation fluid, it gets cumbersome, but also when we put irrigation fluid in, some remains behind. We don't get all of it back out. So if you put 700 or 800 in, you're liable to have 200 remain in the abdomen during that time period. So that's going to kind of throw off your numbers, and it could end up looking a little different than what the situation is. So that's just a couple of ways of kind of trying to simplify this. And it's not a perfect process, but it's much more accurate than doing estimated blood loss. And particularly in this, by using the two-step method, I think it's not going to be all that much of a challenge to your nurse's time or effort in comparison to what it is now. Again, there are things that could be improved upon. There are things that we need to be improving on, and I think this is it. Just get started. As Barbara said, start with either the vaginal delivery, start with the C-section, maybe start with just Dr. Smith's patients. And you don't necessarily have to wait for this to go live to just kind of start training your nurses. An easy way to train them is to say, you know what, every morning, every day shift delivery, we're going to do this, or every night shift delivery, we're going to do this. Whether we actually record it in our electronic health record, whether we actually do anything with it with the physicians, it gives the nurses a chance to practice, as I said, or just with this or that doctor's patients. It gives us a chance to practice, and therefore, when it goes live, your nurses are much better at it and faster at it, which will make your physicians happier and hopefully get a little better buy-in if they can do this in just a couple of minutes of time versus they're trying to learn what they need to do also. There are some resources here. We've already done that, looked at the AWOM page. The Safe Health Care for Every Woman that Barbara was talking about before has got some really great webinars, got a lot of information about this. And then, of course, our website that has links to a lot of different things. Before we move on to the next thing, I want to kind of open it up for any discussion or any comments or questions that you all may have of each other.
I do want to remind you on the Safe Healthcare for Every Woman, the AIM website, we have a link to that on our website. That is where you find the AIM e-module, And those are the little short 10-minute videos that are based on the bundle. They're in the format of the OB hemorrhage bundle, and part of that is quantification of blood loss. So those are a good way to use a tool to use your education of your providers and your nurses on OB hemorrhage and on hypertension. So I would recommend, if you haven't looked at those AIM e-modules, to go to that webpage, and that can be another tool. There's a lot of tools on that page. Any questions before we move to the last slide? Okay, let's go ahead and go to our last slide, where we will show you the Spotlight Hospital criteria. As you recall, this started in 2015, where we're recognizing hospitals that are on the pathway to creating a culture of excellence in perinatal care. So the standard here is excellence, creating excellence. And all of these criteria are things that should be available to all hospitals. We've been working on them and want to recognize those hospitals that are moving forward and meeting these criteria. So those 2016 Spotlight criteria are here, and I'll go over these in a sec. We do have a resource on our website that provides a little more detail as to how these will be measured. They will be awarded at the summit that will be held on September the 6th here at Moore Norman Technology Center. So those Spotlight criteria, the first one will be evaluated from the Hospital Compare website, and that your PCO1 rate will be at or below the national average as of August 31st, 2016. The second one is for the AIM initiative, that your data for quarter 2 2016 is complete and entered by August 31st, that you have a hemorrhage and a hypertension protocol in place, so those are under the structure measures, that you have a quantitative blood loss rate of at least 50% for all of your births, or a timely treatment of at least 50% of your women presenting with severe hypertension. That also is what you'll be entering into your AIM data portal, that you either are a baby-friendly designated hospital or you're in the second stage of development. We have some hospitals that have been hanging out in that first stage for a long time and haven't made any progress. So you can move to that second stage of development, and if you currently have not started this process at all, on our website we have the contact information for Becky Mantle, who can work with you on that. That you also have full participation in the SleepSac program and full participation in the period of purple crying. So if you have any questions or comments, please ask, email us, or give us a call. We're happy to help you if you want to work on these criteria, and we want to make sure that we do provide some recognition for these hospitals that are meeting the 2016 Spotlight criteria. I think last year we had 13. It was either 11 or 13. I'll have to check. They're on our website, hospitals that did meet the criteria for 2016. So go forth and start. We hope that you all are working on these things. If you have any questions or comments, please give us a call or email.